Question 1. A patient in the ICU is diagnosed with early-stage septic shock. Which hemodynamic change should the nurse expect to see on the monitor? A. Increased systemic vascular resistance, SVR. B. Decreased systemic vascular resistance, SVR. C. Decreased cardiac output, CO. D. Increased pulmonary artery occlusion pressure, PAOP. Answer B. Decreased systemic vascular resistance, SVR. The core concept here is that early sepsis causes massive vasodilation, and the keyword early stage points to the initial hyperdynamic phase where vessels relax excessively. Systemic vascular resistance, SVR, measures the tightness or tone of the blood vessels, so when the inflammatory response causes vessels to dilate, resistance drops significantly while cardiac output often increases to compensate. For example, think of SVR like a garden hose nozzle. In sepsis, the nozzle is wide open, causing low pressure even if the flow is high. A simple way to remember this is that sepsis makes the blood vessels floppy and wide, which always lowers the SVR. Question 2. A patient is admitted with cardiogenic shock following a massive myocardial infarction. Which medication does the nurse anticipate administering to improve contractility? A. Norepinephrine. B. Dobutamine. C. Phenylephrine. D. Vasopressin. Answer B. Dobutamine. This question focuses on treating pump failure, and the keyword contractility indicates the need for a positive inotrope rather than just a vasoconstrictor. Dobutamine stimulates beta-1 receptors in the heart, which strengthens the force of the heartbeat and helps the weakened ventricle pump blood more effectively without significantly increasing vascular resistance. In a practical setting, this drug is the go-to choice when the heart muscle is too weak to eject blood, provided the patient's blood pressure can tolerate it. Remember that dobutamine does more for the heart muscle's squeezing power. Question 3. To ensure accurate hemodynamic readings, the nurse must level the transducer to the phlebistotic axis. Where is this landmark located? A. Third intercostal space, midclavicular line. B. Fourth intercostal space, midaxillary line. C. Fifth intercostal space, anterior axillary line. D. Second intercostal space, midaxillary line. Answer B. Fourth intercostal space, midaxillary line. Accurate pressure monitoring relies on physics and gravity, so finding the correct phlebistotic axis is critical for zeroing the system to the level of the right atrium. If the transducer is placed too low, readings will be falsely high, and if placed too high, readings will be falsely low, which could lead to inappropriate treatment decisions. For instance, when a patient changes the angle of their bed, the nurse must adjust the transducer holder to align with this specific point on the chest wall. An easy tip is to visualize the intersection of the line down the side of the chest, armpit area, and the fourth rib space as the bullseye for the heart's pressure center. Question 4. A patient arrives in the emergency department after a diving accident with a suspected spinal cord injury. The patient is hypotensive and bradycardic. Which type of shock does the nurse suspect? A. Hypovolemic shock. B. Cardiogenic shock. C. Neurogenic shock. D. Septic shock. Answer C. Neurogenic shock. The combination of hypotension and bradycardia alongside a spinal injury provides the classic presentation of neurogenic shock. Unlike other forms of shock where the heart rate speeds up to compensate for low blood pressure, this condition involves a loss of sympathetic nervous system tone, preventing the heart from racing and causing blood vessels to relax inappropriately. A real-world example is a patient who remains warm and dry with a slow heart rate despite low blood pressure, because their body cannot trigger the usual fight-or-flight vasoconstriction. Ideally, remember that neurogenic shock is the only shock where the heart rate is inappropriately slow, bradycardia, while the pressure is down. Question 5. What is the primary intervention for a patient presenting with hypovolemic shock due to hemorrhage? A. Administering a vasopressor. B. Starting an inotropic agent. C. Fluid resuscitation and blood products. D. Initiating antibiotic therapy. Answer C. Fluid resuscitation and blood products. The fundamental problem in hypovolemic shock is a volume deficit, so the priority is replacing what has been lost before using other drugs. Pressors or inotropes will not work effectively if the tank is empty, because there is no fluid for the heart to pump or vessels to squeeze. For example, treating a trauma victim involves rapidly infusing crystalloids or packed red blood cells to restore circulating volume and oxygen carrying capacity. Always remember to fill the tank with fluids first before trying to squeeze the pipes with vasopressors. Question 6. While monitoring a patient with an arterial line, the nurse observes a dampened waveform, flat and sluggish. What is the most likely cause? A. The transducer is too low. B. Air bubbles or a clot in the tubing. C. The patient is hypertensive. D. The flush bag pressure is too high. Answer B. Air bubbles or a clot in the tubing. A dampened waveform means the mechanical signal isn't transmitting clearly from the artery to the monitor, often due to an obstruction like air or a small blood clot. This results in a waveform that looks rounded or flat and usually produces a falsely low systolic and falsely high diastolic reading. Practically, the nurse should check the line for kinks, aspirate any clots, and flush the system to ensure the square wave test is crisp. Think of the arterial line like a guitar string. If something is touching it, like a clot, or the tension is wrong, the vibration or waveform won't be sharp and clear. Question 7. Which hemodynamic value best reflects the preload of the left side of the heart? A. Central venous pressure, CVP. B. Pulmonary artery occlusion pressure, PAOP. C. Systemic vascular resistance, SVR. D. Cardiac output, CO. Answer B. Pulmonary artery occlusion pressure, PAOP. The question asks specifically about the left side of the heart, and PAOP, often called the wedge pressure, measures the pressure backing up from the left atrium when the balloon is inflated. While CVP looks at the right side, the PAOP looks ahead through the lungs to see how well the left ventricle is filling and stretching. For example, a high PAOP often indicates fluid overload or left-sided heart failure because the blood is backing up like a clogged drain. A helpful memory trick is that wedge pressure watches the left side WL connection, while CVP watches the right. Question 8. The nurse is caring for a patient with an intra-aortic balloon pump, IABP. When should the balloon inflate to be most effective? A. During ventricular systole. B. During ventricular diastole. C. During the T wave. D. Immediately after the P wave. Answer B. During ventricular diastole. The goal of the IABP is to improve coronary perfusion, and since the heart feeds itself oxygenated blood while it is resting, the balloon must inflate during diastole. This inflation pushes blood backward into the coronary arteries to feed the heart muscle and forward to the rest of the body, while deflation happens right before the heart beats to reduce resistance. If it inflated during systole, it would fight against the heart's contraction, which would be dangerous. Just remember, the balloon pumps, inflates, when the heart rests, diastole, to feed the heart muscle. Question 9. Which medication is the first-line treatment for a patient experiencing anaphylactic shock? A. Diphenhydramine, Benadryl. B. Epinephrine. C. Methylprednisolone. D. Albuterol. Answer B. Epinephrine. Anaphylaxis causes rapid, life-threatening airway constriction and vasodilation, and epinephrine is the only drug that immediately reverses both issues. It works by constricting blood vessels to raise blood pressure and relaxing bronchial muscles to open the airways, halting the reaction's progression. While other drugs like antihistamines help later, epinephrine is the emergency EpiPen shot required instantly to save the life. Ideally, think of epinephrine as the AP everything drug because it fixes the low pressure and the tight airway simultaneously. Question 10. A patient's mixed venous oxygen saturation, SVO2, has dropped to 50%. Which of the following could be the cause? A. Increased cardiac output. B. Hypothermia. C. Shivering or pain. D. Increased hemoglobin levels. Answer C. Shivering or pain. SVO2 measures how much oxygen is left in the blood after it has passed through the body. A low number means the tissues are extracting more oxygen than usual due to high demand. Conditions like shivering, fever, or pain drastically increase the body's metabolic rate, causing cells to eat up more oxygen and leaving less in the returning blood. For example, a patient waking up from anesthesia who is shaking will have a sudden drop in SVO2 because their muscles are working overtime. Remember that a low SVO2 means the body is starving for oxygen and consuming every bit it can get. Question 11. How is mean arterial pressure, MEP, calculated? A. Systolic plus diastole /2. B. Systolic plus 2x diastole /3. C. Systolic diastole /3. D. Systolic x diastolic. Answer B. Systolic plus 2x diastole /3. The MAP formula accounts for the fact that the heart spends twice as much time in the resting phase, diastole, as it does pumping, systole. Because diastole is longer, the calculation weights the diastolic pressure double to get an accurate average pressure perfusing the organs. For a patient with a BP of 120/60, the MAP isn't just the middle number, 90. The formula gives a more precise reflection of organ perfusion. An easy way to remember the math is add 1 systolic to 2 diastolics, then divide by 3 to find the true average pressure. Question 12. Which set of signs would lead a nurse to suspect cardiac tamponade? A. Hypertension, bradycardia, and widening pulse pressure. B. Hypotension, distended neck veins, and muffled heart sounds. C. Fever, tachycardia, and bounding pulses. D. Polyuria, hypotension, and flat neck veins. Answer B. Hypotension, distended neck veins, and muffled heart sounds. This triad of symptoms is known as Beck's triad and is the classic indicator that fluid has accumulated in the sac around the heart, preventing it from filling. The muffled heart sounds occur because the fluid insulates the sound, distended neck veins happen because blood backs up unable to enter the heart, and hypotension results from the heart's inability to pump out enough blood. In a clinical setting, this is an emergency that requires draining the fluid to release the pressure on the heart. Remember Beck's triad. Low BP, muffled sounds, and JVD, jugular venous distension, equals tamponade. Question 13. Norepinephrine, Levophed, is primarily used in septic shock to achieve which hemodynamic effect? A. Decrease heart rate. B. Increase systemic vascular resistance, SVR. C. Decrease myocardial oxygen consumption. D. Dilate the coronary arteries. Answer B. Increase systemic vascular resistance, SVR. In septic shock, the blood vessels are dangerously dilated, and norepinephrine is a potent alpha-adrenergic agonist that tightens these vessels back up. By constricting the vasculature, it raises the SVR and subsequently the blood pressure to ensure vital organs remain perfused. Nurses often refer to it as the first-line pressor because it effectively fixes the floppy pipe problem of sepsis without stimulating the heart rate as aggressively as some other drugs. Think of norepinephrine as the squeezer that tightens the vessels to keep pressure up. Question 14. Which term best describes preload? A. The resistance the heart pumps against. B. The amount of stretch on the ventricular muscle fibers at the end of diastole. C. The force of the mechanical contraction. D. The percentage of blood ejected with each beat. Answer B. The amount of stretch on the ventricular muscle fibers at the end of diastole. Preload is essentially the volume of blood filling the heart before it beats, creating a stretch on the muscle fibers similar to pulling back a slingshot. The more the ventricle fills, up to a point, the greater the stretch and the stronger the subsequent contraction, a principle known as Starling's law. For example, giving a patient 4 fluids increases the volume returning to the heart, thereby increasing preload. Simply put, preload is the stretch caused by volume waiting to be pumped out. Question 15. What is the purpose of performing a passive leg raise puller maneuver? A. To treat deep vein thrombosis. B. To assess fluid responsiveness. C. To reduce intracranial pressure. D. To decrease systemic vascular resistance. Answer B. To assess fluid responsiveness. The passive leg raise is a self-bolus technique where the nurse lifts the patient's legs to drain venous blood back into the heart to see if cardiac output improves. If the heart pumps stronger and blood pressure rises after this maneuver, it predicts that the patient will respond well to receiving actual fluids. It is a safe way to test if the patient needs volume without risking fluid overload by committing to an 4 bag first. Think of PLR as a try before you buy test for fluid resuscitation. Question 16. A patient in shock has a serum lactate level of 6 millimoles per liter. What does this indicate? A. Adequate tissue perfusion. B. Anaerobic metabolism due to tissue hypoxia. C. Renal failure. D. Liver failure. Answer B. Anaerobic metabolism due to tissue hypoxia. Lactate is a byproduct produced when cells are forced to create energy without enough oxygen, a state known as anaerobic metabolism. A level of 6 millimoles per liter is significantly elevated. Normal is usually under 2, signaling that the tissues are starving for oxygen and the shock state is severe. Clinically, we track lactate to see if our resuscitation efforts are working. If the lactate drops, the cells are getting oxygen again. Remember, high lactate equals cellular suffocation and is a warning sign of severe hypoperfusion. Question 17. Which condition is an example of obstructive shock? A. Myocardial infarction. B. Spinal cord injury. C. Massive pulmonary embolism, PE. D. Gastrointestinal bleed. Answer C. Massive pulmonary embolism, PE. Obstructive shock occurs when there is a physical block preventing the heart from pumping blood, even though the heart muscle itself is fine. A massive PE creates a blockage in the pulmonary arteries, preventing the right ventricle from pushing blood to the lungs and left side of the heart. This mechanical obstruction stops blood flow essentially like a cork in a bottle, leading to rapid hypotension. Just remember, obstructive shock is a plumbing blockage problem, not a pump or volume problem. Question 18. Which medication class is most appropriate for reducing afterload in a patient with severe hypertension and heart failure? A. Vasopressors. B. Vasodilators. C. Positive inotropes. D. Anticholinergics. Answer B. Vasodilators. Afterload is the resistance the heart must push against to eject blood, and high blood pressure creates high afterload. Vasodilators, such as nitroprusside or nitroglycerin, open up the arteries, lowering the resistance and making it easier for the failing heart to pump blood forward. This is like opening a door wider so you don't have to push as hard to get through. An easy takeaway is that vasodilators open the gates to lower the workload, afterload, on the heart. Question 19. When measuring central venous pressure, CVP, the nurse is assessing the pressure in which part of the heart? A. Left atrium. B. Left ventricle. C. Right atrium. D. Pulmonary artery. Answer C. Right atrium. The central venous pressure catheter tip sits at the junction of the vena cava and the right atrium, measuring the pressure of blood returning to the right side of the heart. This value gives us insight into right-sided preload and right heart function/failure. If CVP is high, it might mean fluid overload or right ventricular failure. If low, the patient may be dry. Remember, CVP is the central entry point, which corresponds to the right atrium. Question 20. Which of the following signs indicates a patient is in the compensatory stage of shock? A. Hypotension and bradycardia. B. Normal blood pressure and tachycardia. C. Anuria and mottled skin. D. Unconsciousness and irregular breathing. Answer B. Normal blood pressure and tachycardia. In the compensatory stage, the body's defense mechanisms kick in to hide the problem, primarily by releasing adrenaline to speed up the heart, tachycardia, and constrict vessels. This maintains a normal blood pressure despite the underlying issue, often tricking clinicians into thinking the patient is stable. A patient might look relatively okay, but a racing heart and slightly cool skin are the body's way of screaming for help before the blood pressure crashes. The key takeaway: if the BP is normal but the HR is high, the body is compensating and working hard to stay afloat. Question 21. Why can positive pressure ventilation, mechanical ventilation, cause hypotension? A. It increases venous return to the heart. B. It increases intrathoracic pressure, decreasing venous return. C. It causes direct vasodilation of peripheral arteries. D. It slows the heart rate significantly. Answer B. It increases intrathoracic pressure, decreasing venous return. Mechanical ventilators blow air into the lungs under pressure, which squeezes the chest cavity, intrathoracic pressure. This squeezing effect compresses the major veins, vena cava, making it harder for blood to flow back into the heart from the body. With less blood returning, decreased preload, the heart has less to pump out, leading to a drop in blood pressure. Always anticipate a potential dip in blood pressure right after intubation or when increasing PEEP settings because you are effectively squishing the venous return. Question 22. Disseminated intravascular coagulation, DIC, is a serious complication of septic shock defined by A. Excessive clotting followed by excessive bleeding. B. High blood pressure and stroke. C. Rapid healing of wounds. D. Increased production of platelets. Answer A. Excessive clotting followed by excessive bleeding. DIC is a paradoxical condition triggered by severe sepsis where the body's clotting system goes into overdrive, creating tiny clots everywhere that block blood flow to organs. Eventually, the body uses up all its clotting factors and platelets on these microclots, leaving the patient with thin blood that leads to spontaneous bleeding from foresights, gums, or wounds. It is a cycle of clotting then bleeding. A helpful way to view DIC is that the patient clots so much they run out of supplies, and then they bleed because the cupboard is empty. Question 23. Phenylephrine is a pure alpha-adrenergic agonist. What is its primary physiologic effect? A. Increases heart rate. B. Increases contractility. C. Causes peripheral vasoconstriction. D. Dilates bronchial smooth muscle. Answer C. Causes peripheral vasoconstriction. Phenylephrine works exclusively on alpha receptors found in the blood vessels, causing them to clamp down tight without directly stimulating the heart's rate or squeeze. This makes it useful for raising blood pressure in patients who might have a high heart rate tachycardia because it won't make the heart race faster like other pressors might. Think of phenylephrine as pure pipe constrictor. It ignores the heart pump and just tightens the hoses to raise the pressure. Question 24. Before inserting a radial arterial line, the nurse performs an Allen's test. What is the purpose of this test? A. To check for nerve damage. B. To confirm patency of the ulnar artery. C. To measure blood pressure manually. D. To assess venous filling time. Answer B. To confirm patency of the ulnar artery. The Allen's test ensures that if the radial artery, where the line goes, becomes blocked or damaged, the hand will still get blood flow through the ulnar artery. By compressing both arteries and releasing only the ulnar side, the nurse watches for the hand to pink up, proving that the ulnar artery can do the job alone. This prevents the catastrophic complication of an ischemic, gutty hand if the radial line clots off. Remember, check the backup ulnar road before blocking the main radial road. Question 25. Milrinone is often chosen over dobutamine for heart failure patients because milrinone A. is a stronger vasoconstrictor. B. Increases heart rate significantly. C. Decreases afterload without significantly increasing heart rate. D. Increases blood pressure rapidly. Answer C. Decreases afterload without significantly increasing heart rate. Milrinone is a phosphodiesterase inhibitor that serves as both an inotrope, improves squeeze, and a vasodilator, lowers resistance. Unlike dobutamine, which can make the heart race, milrinone relaxes the vessels, reducing afterload, while gently helping the heart pump, making it ideal for patients with high resistance who can't tolerate tachycardia. It is often nicknamed an inodilator because it combines inotropy and dilation. The takeaway: milrinone helps the heart pump easier without making it run a sprint. Question 26. In early hypovolemic shock, what typically happens to the pulse pressure? A. It widens, systolic rises, diastolic falls. B. It narrows, systolic falls or stays stable, diastolic rises. C. It remains unchanged. D. It becomes irregular. Answer B. It narrows, systolic falls or stays stable, diastolic rises. Pulse pressure is the difference between the systolic and diastolic numbers. In early hypovolemia, the body releases catecholamines to clamp down vessels, which raises the diastolic pressure, bottom number, while the systolic pressure, top number, starts to drop or stay flat due to low /volume. This brings the two numbers closer together, known as a narrowing pulse pressure. Ideally, watch for the numbers getting closer at G 100/80 as an early warning sign that the patient is losing volume before the pressure crashes completely. Question 27. When is the administration of 4 corticosteroids indicated in the treatment of septic shock? A. Immediately upon arrival to the ED. B. Only for patients with known asthma. C. When the patient remains hypotensive despite adequate fluids and vasopressors. D. Before starting antibiotics. Answer C. When the patient remains hypotensive despite adequate fluids and vasopressors. Corticosteroids, like hydrocortisone, are reserved for refractory septic shock, meaning the standard treatments of fluid and pressors aren't keeping the blood pressure up. The steroids help support the body's stress response and can make the blood vessels more responsive to the vasopressors being administered. They are not a first-line drug but are added when the patient is maxed out on other therapies. Remember, fluids first, then pressors, then steroids if the shock persists. Question 28. A patient on a ventilator suddenly develops severe hypotension, tracheal deviation, and absent breath sounds on the right side. What is the priority intervention? A. Increase PEEP. B. Needle decompression or chest tube insertion. C. Suction the endotracheal tube. D. Administer a fluid bolus. Answer B. Needle decompression or chest tube insertion. These signs describe a tension pneumothorax, a form of obstructive shock where trapped air in the chest crushes the heart and great vessels, preventing blood flow. The tracheal deviation is a late sign showing the pressure is pushing everything to the opposite side. This is a mechanical problem that drugs cannot fix. The pressure must be released immediately by poking a hole, needle decompression, or inserting a tube to let the air out. The rule is, if the air is crushing the heart, you must pop the pressure immediately. Question 29. Why is cardiac index, CI, a better indicator of heart function than cardiac output, CO? A. CI is easier to calculate. B. CI adjusts for the patient's body surface area, body size. C. CI does not require invasive monitoring. D. CI is measured more frequently. Answer B. CI adjusts for the patient's body surface area, body size. Cardiac output tells you the raw volume of blood pumped per minute, but it doesn't account for how big the patient is. 4 liters per minute might be fine for a small grandmother but fatal for a large linebacker. Cardiac index takes the output and divides it by the body surface area, BSA, giving a standardized number that reflects if the flow is adequate for that specific patient size. Always prefer the index because it personalizes the data. It answers the question, is this enough blood flow for this person? Question 30. Nitroprusside, nipride, is being infused for a hypertensive crisis. What distinct safety measure must be taken with this medication? A. It must be protected from light. B. It must be given via central line only. C. It requires hourly liver function tests. D. It must be mixed with saline only. Answer A. It must be protected from light. Nitroprusside is a potent vasodilator that is chemically unstable when exposed to light, potentially breaking down into toxic cyanide metabolites. To prevent this, the 4-bag must be wrapped in an opaque cover, usually supplied with the bag or foil. While monitoring blood pressure is vital due to its potency, the unique handling requirement is the light protection. Just remember, nitroprusside is shy and needs to be kept in the dark to stay safe and effective. Question 31. According to the sepsis bundles, when should broad-spectrum antibiotics be administered? A. Within 3 hours of admission. B. Within 1 hour of recognition, after blood cultures are drawn. C. Only after the lactate result is back. D. After 2 liters of fluid have been infused. Answer B. Within 1 hour of recognition, after blood cultures are drawn. Time is tissue in sepsis, and delaying antibiotics increases mortality significantly. The guidelines state that antibiotics should be started within the first hour of recognizing sepsis to fight the infection immediately. However, it is crucial to draw blood cultures before starting the drug, so the bacteria can be properly identified without the antibiotic masking the results. The golden hour rule is cultures first, then antibiotics immediately. Don't wait for anything else. Question 32. How does hypothermia affect the coagulation system in a trauma patient? A. It enhances clotting and prevents bleeding. B. It impairs platelet function and clotting factors, increasing bleeding risk. C. It has no effect on coagulation. D. It causes blood to become thicker and clot too easily. Answer B. It impairs platelet function and clotting factors, increasing bleeding risk. The enzymes that control blood clotting function best at normal body temperature. When a patient gets cold, hypothermia, these enzymes stop working and platelets fail to stick together. This leads to coagulopathy, causing the patient to bleed uncontrollably even if they have enough blood products in their system. This is part of the lethal triad of trauma, hypothermia, acidosis, coagulopathy. A practical tip. Keeping the trauma patient warm is not just for comfort. It is a medical intervention to stop them from bleeding to death. Question 33. Vasopressin is often added to norepinephrine in septic shock. What is its mechanism of action? A. It is a beta blocker. B. It stimulates V1 receptors to cause smooth muscle contraction in capillaries. C. It is a potent diuretic. D. It increases heart rate and contractility. Answer B. It stimulates V1 receptors to cause smooth muscle contraction in capillaries. Vasopressin is a naturally occurring hormone, antidiuretic hormone, that, at shock doses, stimulates V1 receptors in the vascular smooth muscle to constrict. It works differently than the catecholamines, like norepinephrine, so it provides a second way to tighten blood vessels and raise blood pressure without adding more adrenergic side effects. It is often used as a sparing agent to reduce the dose of norepinephrine needed. Think of vasopressin as the assistant manager that helps clamp down the vessels when the first drug needs help. Question 34. A patient with pericardial effusion is showing signs of hemodynamic collapse. What is the definitive treatment? A. Administration of diuretics. B. Pericardiocentesis. C. Beta blocker therapy. D. High-dose corticosteroids. Answer B. Pericardiocentesis. When fluid in the pericardial sac compresses the heart, tamponade, the heart cannot fill, and medications like diuretics or pressors won't fix the mechanical squeeze. The definitive fix is to physically remove the fluid, usually by inserting a needle through the chest wall, pericardiocentesis, or surgically draining it. This immediately releases the pressure, allowing the heart to expand and pump again. Always remember, fluid squeezing the heart is a mechanical problem requiring a mechanical solution, a needle. Question 35. What is the end-stage complication of prolonged, untreated shock where 2 or more organ systems fail? A. Systemic inflammatory response syndrome, SIRS. B. Multiple organ dysfunction syndrome, MODS. C. Pulmonary embolism. D. Diabetic ketoacidosis. Answer B. Multiple organ dysfunction syndrome, MODS. If shock is not reversed, the prolonged lack of oxygen, hypoperfusion, causes cells in the kidneys, lungs, liver, and heart to die, leading to MODS. It is a progressive failure where one organ system crashing, like the kidneys, puts stress on another, like the heart, creating a domino effect that is very difficult to treat. It represents the final, often fatal, pathway of severe shock. The concept is simple. Shock is the insult, and MODS is the resulting failure of the body's machinery due to that insult.